So headaches are something that affect a lot of people, very often, and they result in millions of ER visits every single year. Now, sometimes they're just a headache. They're annoying, they're problematic, but they're not life-threatening. But other times there can be a life-threatening underlying cause. So it's important for us as providers to differentiate between these non-life-threatening and these life-threatening causes of headache. And a lot of times that's going to be in the history. Explore that chief complaint. Use your OPQRST. Find out if there's any kind of change in the pattern from any other previous headaches. And make sure that you also are going to identify any associated signs and symptoms. So we've got two classifications of headaches. We've got a primary headache syndrome and a secondary headache syndrome. Now, in both cases, the problem is not the brain itself, because brain tissue is insensitive to pain. It doesn't feel it. But it's the pressure or tension on the pain-sensitive structures around the brain or in the muscles of the scalp and the neck and sometimes the upper back. Pain in the sinuses, the teeth, the jaw can also be interpreted as a headache as well. Another cause of headache could be like abnormal neurotransmission or neuralgia. So your primary headache syndromes are going to include migraines, clusters, and tension headaches. And then your secondary are going to be caused by other problems, some of which can be life-threatening. So a migraine is going to be abnormal nervous system pain transmission, and they think that it's due to a neurochemical origin with similarities to epilepsy, but they're not really sure. It is kind of familiar. There has a familiar tendency with it, and migraines occur more frequently in females than males. Typically, your onset of migraines are going to start in younger ages, and they may last minutes to hours, and they usually have a gradual onset of intense throbbing pain that is unilateral. They may have some kind of aura prior to the onset of this headache, such as flashing lights or things like that. There may be a known trigger for some patients, like some alcohol, certain foods, medications, things like that. Oftentimes this pain is going to be accompanied by your photosensitivity or light sensitivity, nausea, and vomiting. Pretty much any neurological sign or symptoms possible. And there are quite a few variants of a typical migraine experience. So just be aware of this. Noise, light, movement, other things like this can make it exacerbate these migraines. So if you're transporting somebody with migraine, make sure that you provide a dark, quiet environment. A damp, cool cloth on the forehead or over the eyes may give a small amount of relief. And contact med control about any use of antiemetics like Zofran or other analgesics that are in your local scope of practice. Your cluster headaches are uncommon and mostly occur in males, and they're going to be sudden onset of a series of severe headaches of short duration. They're usually going to be unilateral, generally around the temple or around the eye. Unlike other headaches, there is some kind of indication that high-flow oxygen may be useful in relieving some of this pain from your cluster headaches. Now your tension headaches, all ages, male, female, across the board, and this is usually kind of a dull, nagging pain that extends from the shoulders and neck up to the scalp. They may experience muscle soreness or a feeling of muscle tightness with that headache. These may be associated with abnormal serotonin levels or other neurotransmitter activities. And sometimes some of your SSRIs can actually be prescribed to help with frequent tension headaches. Now your secondary headache syndrome, there's a wide variety of underlying causes, including vascular problems, central nervous system infections, glaucoma, hypoxia, toxins, high altitude, tumors, hypertension, a whole lot of stuff here. So your vascular causes are going to include your intracranial hemorrhage, your dissection of the internal carotids, and your vertebral arteries that supply the brain as well, and the inflammation or spasm at the temporal artery. Hypoglycemia, carbon monoxide, fever, dental problems, preeclampsia, and hypertension are also causes. And it's not uncommon to get a headache after a lumbar puncture. And what they usually have to do there is they actually go in and do a patch procedure to help mitigate that headache that can occur afterwards. Another cause of or more serious potentially cause of your secondary headache is going to be a subarachnoid hemorrhage. Right, and that's where the bleeding accumulates between the brain and the arachnoid layer, the meninges. And this is typically a sudden onset of severe headache, unlike any headache they've ever experienced. It could be diffuse, or it could be located in the occipital region and may include neck pain. Nausea, vomiting, and ultramostatus can also occur, along with some other neurological deficits. The subarachnoid hemorrhages can be precipitated by an activity that raises blood pressure, like coughing, defecation, exertion, or it can occur spontaneously. There are some classic signs and symptoms like this, but up to 50% of patients have normal vital signs, normal level of responsiveness, no neck pain, no stiffness.